Hello everyone, and a very warm welcome to this explainer. Today, we're opening up an absolute classic, a truly essential chapter in medicine. We're diving deep into hypothyroidism. And to do this right, we're using the ultimate gold standard starting template, Harrison's Principles of Internal Medicine. Whether you're a medical student, a healthcare professional, or just someone fascinated by how our bodies work, this structured breakdown is going to make the science crystal clear and super easy to remember. Let's get started. Okay, let's dive into this. Think about the thyroid gland sitting right there at the front of your neck as the master engine of your body. It literally sets the speed for your entire metabolism. When this engine gets plenty of fuel, everything hums along perfectly. But when it slows down and stops pumping out enough hormone, well, the whole system takes a hit. From your brain to your heart, right down to your digestion, it all suffers a massive system-wide slowdown. So here's our agenda to solve this clinical mystery step by step. 1. Understanding hypothyroidism. 2. The root causes. 3. Spotting the symptoms. 4. Laboratory diagnosis. 5. The gold standard treatment. And finally, 6. Special cases and takeaways.
Kicking things off with Section 1. Understanding hypothyroidism, the body slowdown.
Now, this is incredibly common, affecting roughly 4 to 5% of the global population, especially women and the elderly. By definition, hypothyroidism is a deficient production of thyroid hormones, but Harrison's makes a really crucial distinction here, splitting it into 2 categories, overt and subclinical. Overt disease, that's when you have high TSH and low free T4, causing obvious undeniable illness. Subclinical, on the other hand, means your TSH is elevated, but your free T4 is actually still in the normal range. But here's the thing. Even in its milder forms, this hormone deficiency creates a multi-system slowdown that messes with your cardiovascular, neurological, and reproductive functions.
Moving right along to Section 2, the root causes, where the system breaks. And this brilliantly illustrates the whole chain of command in the body. Step 1, your hypothalamus up in the brain releases TRH. Step 2, this signals your pituitary gland to secrete TSH. Step 3, that TSH yells at your thyroid to make hormones, mainly T4 and a little bit of T3. And finally, Step 4, your peripheral tissues convert that T4 into the active T3. The absolutely crucial thing to grasp here is that a disruption at literally any single step in this chain will cause hypothyroidism. So what actually causes that disruption? Well, primary thyroid failure, where the gland itself just quits working, accounts for a whopping 95% of all cases. In parts of the world where people get plenty of iodine in their diet, an autoimmune condition called Hashimoto's thyroiditis is usually the main culprit. But there are definitely other buckets to consider too, like nutritional issues such as iodine deficiency, iatrogenic causes like past thyroid surgeries or neck radiation, and even congenital defects that are present right from birth. Before we move on from the causes, I've got to highlight a massive clinical pearl straight out of Harrison's. If you're a med student or a doctor tuning into this explainer, pay close attention to the drug amiodarone. Because it's loaded with iodine, it can actually cause both hypo and hyperthyroidism. It does this via the Wolff-Chaikoff effect and direct cytotoxicity. So, the takeaway? Always keep a close eye on the thyroid panel for patients taking this specific heart medication. Next up is Section 3, Spotting the Symptoms, the clinical picture. Honestly, the symptoms make total sense when you think about a slowed metabolism. Metabolically speaking, the engine isn't generating heat or burning fuel right, so patients experience intense cold intolerance, unexpected weight gain, and severe constipation. Neurologically, everything just feels sluggish, right? That leads to memory issues and slow thinking. Cardiovascularly, the heart rate drops, causing bradycardia, and bad cholesterol like LDL starts building up in the blood. And reproductively, this slowdown can cause heavy periods, called menorrhagia, and even infertility. Like we said, it is a total body slowdown. Let's jump right into Section 4, Laboratory Diagnosis, Solving the Mystery. All right, so how do we figure out exactly where the problem is coming from? If the thyroid gland itself is broken, which we call primary hypothyroidism, the brain essentially screams at it to work harder. So you're going to see an elevated TSH alongside a low free T4. But if the problem is central, meaning the brain's pituitary or hypothalamus is the issue, the TSH will actually be low or normal, even though the free T4 is low. Your TSH really is your ultimate compass here. Once we nail down that it's a primary thyroid issue, we need to know if it's autoimmune. That's where our specialized diagnostic tools step in.
Testing for anti-TPO antibodies is incredibly effective. We're talking 90 to 95% sensitive for Hashimoto's, making it the absolute best marker for autoimmune destruction. Antithyroglobulin is helpful too, just a bit less specific. And hey, if the antibodies come back negative but your clinical suspicion is still high, an ultrasound is a fantastic backup tool, usually showing a dark, heterogeneous hypoechoic gland.
Now for the most important part, Section 5, the gold standard treatment, fixing the engine. So the crucial point is how we fix this. Levothyroxine pills, often just called LT4, are the absolute cornerstone and the gold standard of hormone replacement therapy. It's literally identical to the T4 hormone your own body makes naturally. But, and Harrison's really emphasizes this, you can't just hand this out uniformly to everyone. The dosing has to be strictly individualized for every single patient.
Let's break down this highly specific treatment protocol step by step. Step 1 is initiation, generally starting at 1.6 micrograms per kilogram of body weight per day for healthy adults. Step 2 is administration, and listen up, this is absolutely critical. Patients must take this medication on a completely empty stomach, 30 to 60 minutes before breakfast. You cannot take it with calcium, iron, or antacids because they'll block absorption. And finally, step 3 is monitoring. You've got to check the TSH at 6 to 8 weeks to see if that dose needs a tweak.
Finally, Section 6, special cases and takeaways, real-world impact. 30 to 50. Now, that is a massive number. It represents the percentage increase in thyroid hormone demand during pregnancy. Since a growing baby relies entirely on the mother's thyroid hormone during that first trimester, a pregnant woman's dose of levothyroxine often needs to be bumped up by 25 to 30% the very moment pregnancy is confirmed. Untreated hypothyroidism in this scenario carries severe risks. We're talking miscarriage, preeclampsia, and impaired fetal brain development. It's incredibly serious.
Now, what's really interesting about this next point is how we treat elderly patients. We completely flip our approach. While we might give healthy, younger adults full doses right away, an older heart just cannot handle a sudden rush of metabolic fuel. So, for the elderly, we start very low, just 12.5 to 25 micrograms a day, and we titrate up super slowly. We're also okay accepting slightly higher TSH targets, like 4 to 6, just to avoid triggering heart problems like arrhythmias or causing bone density loss. It's a much more gentle, cautious process. All right, let's bring the whole shebang together into 4 major clinical pearls, straight from Harrison's guidelines. Number 1, TSH is your diagnostic cornerstone, but always, always interpret it alongside free T4. Number 2, treat the patient, not just the lab numbers. Look at their actual symptoms and their age. Number 3, pregnancy demands immediate and proactive management. And number 4, the administration technique really matters. Taking that levothyroxine on an empty stomach absolutely determines its success. Ultimately, I want to leave you with this really reassuring bottom line from Harrison's. Hypothyroidism is highly treatable. Early recognition, accurate diagnosis, and individualized therapy restore quality of life. I think it's just incredibly empowering to know that modern medicine can take such a complex, systemic slowdown and effectively fix it, bringing all that energy and vitality right back into a patient's life. Which leads me to ask you, based on everything we've unpacked today, could those subtle signs of fatigue, brain fog, or cold intolerance in you, your patients, or your loved ones be a signal to check the metabolic engine? Keep your eyes open, listen to the body's clues, and remember the structure we've built today. Thank you so much.